is not a disease. Pain is not a disease, but it's actually a symptom of something going on. It lasts for short periods of time, acute pain, and is usually easily treated. And once you've addressed the cause, it disappears. So let's look at chronic pain. Chronic pain is something very different. And over 1/4 of the United States citizens suffer from chronic pain. It's the most common complaint seen in physicians' offices, NP offices, outpatient clinics, and very often people will go to emergency departments complaining of chronic pain. The United States spends over $100 billion a year on healthcare costs just related to pain management. Failure to manage chronic pain often leads to other problems, such as opioid dependence and increased morbidity and mortality. And that's one of the reasons addressing it and looking at it holistically is so important, because part of the opioid epidemic that we have been talking about is related to the fact that many people started out with pain syndromes. They were treated with opioids, and then they had a dependence on them and can't easily get off them. It's not a, quote, emotional need for the medication, but in their eyes, it's a physical need for relief. And it's very difficult for them to give this up. Other aspects of the opioid epidemic, we realize, is because of medication that is easily coming into the country and people are getting illicitly. There is an increased morbidity and mortality that's associated with chronic pain. Go ahead. One of the things that we see with chronic pain is an increase in suicidal thoughts and ideations, and it really interferes in the quality of life. How we define it is as a long-standing pain that persists beyond the usual recovery period. And that definition goes between longer than 3 to 6 months. So someone that's experiencing pain that lasts longer than 3 to 6 months is considered to be experiencing a chronic pain syndrome. Traditional pain relief interventions do not alleviate the pain. And so if we use medications very often that affect the brain in an area that addresses just the pain tracks, we're not going to get at all the other aspects of the pain. And eventually more and more of that medication is needed to help patients. So let's look at what the chronic pain cycle is. The patient has pain, and that causes changes to the nervous system. Without getting complicated, what happens is pain travels along tracks in the nervous system through the spinal cord and to areas in the brain of the thalamus, which then takes that sensory information and sends it upwards to the cortex where it's defined. Acute pain travels on fibers that are short and fast. Chronic pain travels on fibers that are longer and very slow. And so one of the things that enhances the chronic pain is the fact that these fibers are continuously stimulated, whereas the acute pain fibers are not. Anxiety occurs because the pain is signaling tissue damage and harm, and the brain starts to change its focus on that pain. And then changes take place in the nervous system where the perception of that pain is altered. So there's more pain. The more pain, the more anxiety, the less movement. And in certain areas of the body, the less you move those areas, they have a tendency to become stiff and become more painful on movement, which again changes the nervous system and its potential and how it looks at the pain experience. So now you see it's a cycle. So what has to be done is somewhere along that cycle, it has to be broken. And that's why we start with medications and find that it just doesn't work in chronic pain syndromes. So looking at it in the beginning, the medical treatment of chronic pain is how providers manage the individual's chronic pain really, really causes a profound and long-lasting effect on the quality of life for a patient. And so some of the things that we look at, especially in practices like I'm in, where we have people with chronic pain, we look at pain scale tools to quantify. And if any of you have ever gone to your practitioner and they will say to you, are you having any pain? And can you rate it on a scale of 1 to 10? That's a quick assessment, but there are better pain measurement inventories that in practices where we deal with pain all the time, we look at those. So the McGill Pain Questionnaire is one, and that includes actually a drawing where the patient can put exactly where their pain is. There's a questionnaire regarding previous pain medication use and the past experiences with pain along the McGill. The brief pain injury just assesses the patient's beliefs on pain and the impact of pain in their lives. For children, what we use are faces, and they point to the face that tells us the type of pain that they're experiencing, because it's very difficult for children to quantify and qualify pain, because in reality, pain is a qualitative experience. And what we as practitioners have to do is help patients quantify it for us. So when we screen for depression and we look at pain, this is very important. And one of the recommendations is that we do this with chronic pain. And so the Minnesota Multiphasic Personality Inventory, or the Beck Depression Scale, are very good for doing this. Okay. So from my point of view, because I work with people all the time that have chronic pain, we've developed a more holistic approach. So it's a combination therapy. So we don't just look at medications and pharmacological therapies. We also look at non-pharmacological treatment options for pain. And research has indicated that a more significant reduction in pain and a greater quality of life occurs when we use a combination therapy as compared to using any form of a single therapy, such as just medication. Another thing that is coming forward is the use of what we call centering care, which developed in pregnancy care, and is a form of a group-based model of care with a group visit where individuals who have a similar problem get their appointments on the same day. And what happens is a provider talks about different things with the group, and the group shares some of the things that they do to help with their pain management or any issues that they may be having outside of their visit. And they each get a singular visit with the provider, but that group aspect seems to assist them in understanding that there are people out there that have a shared experience, and this is what they do to help. And so it's very effective. So one of the things that we look at is the need for mental health services as part of a treatment plan. There are a variety of medications that we use in practice that interrupt parts of the pain cycle that I showed you before. We use medications that slow down the pain stimuli that travel to the brain. And by not allowing those impulses to get through, the perception of pain is altered and the pain is decreased as far as the brain sees it. So that's one method. We do not use any opiates in the practice that I'm in for one of those reasons. So that because we do not want patients to become dependent on them. So there are a variety of medications that we use outside of that. You see many of them on TV, Cymbalta, Lyrica, the tricyclic antidepressants that are used for depression, we use a lot for pain management. So those are some of the things we use. For patients that have a disorder that we can treat that enhances their pain, we will use biologics, and you also see those advertised on TV: Humira, Enbrel, Xeljanz, Rinvoq. These are medications that we use, but what they do is they treat an inflammatory response, which is causing the pain. So one of the things that we do realize is over 67% of patients who have chronic pain also suffer from a comorbid mental health disorder. And family dysfunction is a very common symptom when a member suffers chronic pain, because that particular family member can't participate in the family structure as much as they would like or how everybody else thinks they should. So depression and anxiety are very prevalent along patients with chronic pain. And the pain becomes the focus of their life. It is all consuming. Now, this is where I get into what I said to you before about primary gain and secondary gain. In some cases, due to past experiences with pain, individuals have realized that if they experience pain, that they get something out of that pain experience from someone else, whatever that may be. It's sort of a second reward. Other people, the pain just becomes all consuming and it just controls their lives. So one of the things we want to do is interrupt that particular cycle. As a medical professional, I don't have that particular expertise. But the other thing I do know is that patients who have chronic pain are also at an increased risk of suicide. So I'm very careful when I work with my patients who suffer from chronic pain to ask questions to gather that information. Go ahead. So it's important to refer to mental health services when patients don't seem to be able to get a handle on their pain. When physical therapy, I recommend Pilates, I recommend walking, swimming, all forms of an exercise regimen, because that also helps in alleviating chronic pain. When these things don't work and patients are still in pain and seem to have some form of anxiety or depression, it's important to refer. Because one of the things said by Adam Braverman is you can't go through life allowing pain to dictate how you behave. So it's a question of the patient learning to control and become the center of the control of the pain without allowing the pain to control them.
Sorry, I was talking, I was muted, forgot. So that's when I come in the role of the psychotherapist or the mental health practitioner. Okay. So we all know the common symptoms of depression are feeling sad, anxious, worthless, or guilty, sleeping more than usual, being unable to sleep at all, poor concentration, confusion, loss of appetite, or very hungry. And so when they're coming to see me, they've already had the diagnosis, they've already felt the pain for a very long time. And there is some form of treatment plan now, but there's the other things going on with either themselves individually or issues going on with the family because of the pain, just as, was just said that, the family has these expectations that you should still be doing the activities, just, okay, feel the pain, come on, you need to be hiking or you need to be at this show. I'm sorry you have a headache, or I'm sorry your bones hurt, but these are your responsibilities. So some of the psychological and psychosocial treatments for chronic pain and depression are mindful-based approaches, cognitive behavioral therapy, relaxation techniques, narrative therapy. So we're going to go over some of these in the next couple of slides. So the first one with the mindful-based approach, it is an evidence-based approach. It reduces and reports of pain. It also reduces the stress and increase the coping capabilities to reduce the pain and lessen the psychological distress. It also will target the sections of the brain. So like for one thing, you can think of self-regulation, regulating the pain, the emotions, and actions without outside help. So trying to do it, maybe you have the client that doesn't want the medication or they're allergic. I mean, that's the other thing to think of. There's some of these medicines that cause an allergic reaction, especially somebody who's highly allergic to a lot of things, they can't take anything. So then you have the attention to reorient, not allowing a distraction, thought, or feeling to linger or shifting. So you want to restore the ability to mentally manage the pain and the emotion and the behavior. So you're going to change the thought or feeling. You're going to become more aware of your thoughts. You're going to look at something a second time and determine its meaning, where the pain is. What, are you under stress today and the pain is more vigilant? So you want to increase the ability to bear the unpleasant feeling without the distress. So a lot of these mindful exercise, help individuals. The other approach, which you're all familiar with, is cognitive behavioral therapy. So you're helping people to identify and develop the skills to change the negative thoughts and behaviors. The goal is to disrupt the problematic cycle of the thoughts and the behaviors and the feelings. So which are responsible for the pain. So you can change their awareness of the pain and develop better coping skills. You want them to look at the pain differently. You don't want them to focus only on the negative thoughts of the pain, but how they can embrace the pain and change the way they focus on the pain. Like, earlier, Dr. White said that, that either there's two approaches where the pain consumes you. That's the purpose with cognitive behavioral therapy, not to let the pain consume you, to learn a different way to adapt to the pain. So cognitive behavioral therapy helps to provide pain relief in a few ways. Change the way they view the pain, change the thoughts and emotions and behaviors related to the pain. Look at it and change the physical response in the brain. Say to yourself, what is this pain doing for me? Why? Can I change the way I'm looking at it? Putting a different spin on it. ZPT reduces the arousal that impacts the chemicals. So there's other, CBT is not used alone. And we know that in different modalities with different other issues like medication with chronic illness, physical therapy, weight loss, massage. Another thing is motivational interviewing as well that you can use with CBT. So we encourage the problem to solve the attitude with CBT. The other thing is, if you're going to use CBT, it involves a lot of homework at times. So I always tell the client that a lot of the work is going to be done outside of this room. Just know that, don't think it's a quick fix. There's going to be other things that you would like to be doing to help you. It fosters life skills and it allows you to do it yourself. The goal is to teach them. So if they're doing it years from the time they're seeing you, they go back to learning the skills that we have taught them and they can implement them. So some relaxation techniques are meditation, breathing, visualization, progressive muscle relaxation. You want to consider that these are the most available, effective treatments for chronic illness. And it's also cost effective. So the reason why we talk about relaxation techniques, or it reduces the chronic pain through the triggering pain process in the brain. It also reduces the stress after practicing relaxation techniques, which may influence the experience of the pain. So I come from a very strength-based model. So I usually come from a narrative therapy or a solution focus. But when I'm working with clients in chronic pain, I come from a narrative therapy approach because it's strength-based and it helps the individual establish a new identity through discovering positive experiences, even through chronic pain. I want them to investigate their dominant story with these other associated stories. So the dominant story is the impact of the illness. That's all they're focused on. That's all they see now. And they associate themselves with that illness. And so the associate story is learning how to cope with the illness. What is their new world or their new life or their new normal will look like for them? So it's suitable because I have them have externalizing conversation, reauthoring conversations, outside witness. Try to have them facilitate exploration of their individual coping with chronic pain. I really have them focus themselves separating from the chronic pain. So they are not the chronic pain. They are still Alyssa, but there's another part of Alyssa now. Alyssa now has some form of chronic pain that's affecting what Alyssa used to do. And I try to help them look at that Alyssa's not gone, but there's a new Alyssa. And what does that new Alyssa look like? But you don't have to embrace the chronic pain. You just need to learn to live and adapt to it. So it's important to bring the language and share back the experience of the pain and the resistance to pain outcomes. I have them define the pain. At times, I might even have them rename the pain. Instead of calling it pain, tell me something else. What does it remind you of? And if they come up with something negative, I ask them, well, with that term, do you think of something positive or negative? And if they say, well, I still think of it as negative, well, what could you look at it as a positive? It's important to address the pain's isolating and marginalizing effects, because it is. They feel like they're not who they were, especially someone who's always had chronic, like think of someone who's had chronic back pain. Then they go through surgery and they go through all of the rehabilitation, but now they see themselves as somebody very different. They feel like, oh, I walked better when I had the chronic back pain than I had the surgery, because they still are viewing themselves as that person who had the back pain. They're not looking at a new version of themselves. And with narrative therapy, you help them create this new version. And sometimes what I have them do is, you're going to create a book. List the title of the book and the first 4 chapters of the book. And each chapter of that book, what would you write in it? What are the expectations of that chapter? So when you're promoting a positive outcome, chronic pain is whatever the individuals say it is. Like Dr. White said, we can't put a label on someone's pain. That's what they're experiencing. We're not feeling it. And as the therapist, I take the one step down approach. I'm not the expert. I'm not walking their shoes. I don't feel their pain. I'm only there to help them understand their pain, how to work through their pain, how to get the system that they're involved with to understand their pain. Pain experience is unique to each person. Medication is only a small part of chronic pain treatment. For some people, it can work. For some people, they need more. It's not always an end all. So the multidisciplinary approach is needed to address all aspects of the chronic pain and experience. And as a mental health intervention, along with the non-pharmacological methods, it produces the most positive outcome as it changes the way the person perceives the experience and the locus of control. I don't know if Dr. Weiss, you have more to add to the conclusion.
No, I guess we just have some questions. I didn't want to go into the whole physiological aspect of it because it's detailed, but I'm open for any questions. And if anyone wants to know any of those, concepts, I'm here.
Well, I want to thank you for everyone for listening, and any questions?
If you have any questions, you can unmute and verbally ask your question if you'd like. I have a question then. As someone with chronic pain, one, where in the heck do you find people like you, Alyssa, who work with chronic pain? Because I have been through 3 or 4 therapists and none of them really have worked with chronic pain. But also as a person learning to be a counselor, like, what do you recommend to be able to help people with chronic pain? Like, what kind of, is there like a specific class or like anything, like what do you recommend like we focus on, I guess, when we are going through our learning?
So for me, I was very into narrative therapy. So when I was researching narrative therapy, because my whole specialty was when I was in my doctoral program, because I also have my master's in special ed. So I work with children with families with special needs. And so I went through it with a narrative approach. So as I was researching with autism and all that to help them, I came through a lot of research on chronic pain and narrative therapy. So I would read a lot of articles on that. And also with Dr. Weiss being the family nurse practitioner working in that setting, she and I would collaborate on, she would be talking about things and I would do more research. So I did a lot of research on my own and then just took the model that I used and worked in it that way, because you'll be exposed to a lot of individuals with depression, and chronic leads to depression. I mean, they first come in saying to me, I might not even know that they have a chronic illness because they'll come in and say, I'm depressed. And once I start, talking to them and everything, it comes to the fact, well, I have a chronic illness and I was diagnosed, a year ago or 2 years ago. And then I go through it in that way. I've attended some conferences with chronic illness. So that's how I've really learned and really became specialized in it. To find someone, most people would put it on, that I've worked with people with chronic illness, when they talk about themselves on different, I guess, websites to find a therapist. But, ask the question if you find a therapist, listen, this is my main issue is chronic illness. And it's hard for me to function on a daily basis. You know, I'm in constant pain and I have all of this going on and I'm trying to balance it all plus the pain. And I'm trying not to see the pain. So, I mean, the one thing you always want to look at is in any case with anything, you want to try to separate. You're not the chronic illness. You're you. It's just part of you, like everything else. What makes you who you are? I don't know if that answered your question or that was...
It very much did. Thank you. We did have a question in the chat. Hannah asked, have you ever treated a pregnant patient who was dealing with chronic pain? I think it was when Dr. Sally Weiss was talking, but I can't remember. So whoever wants to answer that, I guess between the two of you.
The answer to that is yes. Okay, and there are medications that can be used. There are antidepressants that also affect pain transmission that are allowed during pregnancy. We try desperately not to do that. So we focus more on non-pharmacological methods. So we have referred patients not only to mental health if they're pregnant with chronic pain, because we do deal with it with patients. Acupuncture, which will not harm the baby at all. We promote exercise such as swimming, prenatal yoga, prenatal Pilates. And when that changes the focus more to me versus the pain, patients do much better. So our first approach is definitely to get away from any medications if possible. Now, in some cases, we have patients that have autoimmune disorders where they have been on medications like the biologics, and these need to be stopped. And so that's when we get into the aspect of the chronic pain and being pregnant. But we cannot use those medications during pregnancy. And we actually advise our patients if they're thinking of becoming pregnant, they need to let us know because those medications have to be stopped several months in advance of becoming pregnant because of their long-term lasting in the body. So does that answer that question? That's actually a very good question.
Another thing that we recommend too is hypnosis. And that's another treatment modality is hypnosis that a lot has been done with chronic pain, is a form of hypnosis to do that with. But some people are skeptical with hypnosis. They keep thinking that they're gonna like quack like a duck or you're gonna make them jump. So they're not, I haven't had many clients at first, you talk to them about it, but I have met some clients that are just very hesitant about it until, you explain you're not going to be like on the television show standing up and quacking like a duck or anything. There are benefits to the hypnosis and stuff.
And the other approach is the autogenic approach, which Dr. Weiss mentioned in her presentation, where it is by using positive, affirmative, quiet statements to yourself, like, this part of my body feels very warm. This part of my body is loosening up. You're actually addressing what we call the autonomic nervous system. And it has that name because it's automatic and we really can't control it. It's the sympathetic versus the parasympathetic systems in the body. And by doing that, using the autogenetic approach, and you're telling the body to quiet down. So you're trying to address your parasympathetic system because your sympathetic is your speed up, your fight and flight. And you're trying to say to your parasympathetic system, relax my muscles, do this, because that's where that system works, on the smooth muscle and the smooth tissue, things like that.
Hannah comments that she's found chronic pain that is caused by pregnancy is often written off, but still is very debilitating and treatable.
Yes, absolutely. But again, chronic pain caused by pregnancy, remember the fact that the pain has to be present for a minimum of 3 to 6 months to be chronic pain. And so what has to be determined by the provider at that point in time, if the patient is having back pain, was that pain that was established prior to the pregnancy, Or is that pain have its onset during the pregnancy because of the anatomical changes of pregnancy? In which case that makes it a little different. We have had patients who, of course, who have injured their back during a pregnancy for whatever reason, you know, a disc injury and so on. And again, what we do is we use physical therapy, we use relaxation, massage therapy, heat, and so on that can be used during pregnancy. But that's, you know, where you're getting into a slippery slope. So it's very important for a provider to determine when was the onset of the pain, where is the pain, and is it associated with any other possible disorder, such as rheumatoid arthritis, lupus, fibromyalgia. Was it present before? Things like this. These are chronic pain syndromes that we see a lot in our practice.
Okay, we have another question, or can you speak a bit more on the importance of counselors with chronic pain protecting themselves / practicing appropriate boundaries when working with clients who are seeking counseling related to their chronic pain?
Say that again.
It's in the chat as well.
Can you put up the chat? Let me.
Yeah, I can read it again. Ami would like you to speak a bit more on the importance of counseling with chronic pain.
Okay, so you're saying that the counselor has the chronic pain as well and working with someone with chronic pain?
I'm more than happy to explain it. It's fine.
I'm sorry.
That's okay. My name is Dr. Amy Crowley. I'm one of the conference coordinators and also an associate professor here in our counselor education department. And really the crux of my question is, as an individual who has experienced significant medical issues in recent months and has had a very debilitating chronic pain disorder since the age of 11, I often find that there's a over-identification where clients are trying to, will you understand because you also have this, or you've been battling this for years, and constantly having to reinforce those mental and physical boundaries with clients regarding my experience may inform my work with them, but doesn't necessarily mean that I understand their experience. And I know many of our participants in the room today are current students. And so I think it would be really helpful for them to hear from both of you about what it's like to be an individual who may have chronic pain disorders, significant health issues, and then have clients who are seeking services for the very same issue, knowing that it's something that's pretty both mentally and physically taxing.
You want to go first?
Sure, because I see it all the time. One of the things is, as providers and establishing relationships with patients, and I think nurses are more similar to counselors than physicians are, just because that's the way we begin our education. And our goal is always that therapeutic relationship with the patient. We have to always be careful with that self-disclosure boundary. How much do I let the patient know about myself? So also, and that then becomes the empathy versus the sympathy. And so you have to be able to, as a provider, say to you never say to this patient, I understand, because you don't. What you can say, though, you call them clients and I call them patients, but basically to the individual, what you can say is, the one thing that I do know is that this is an individualized experience, and no two people who have chronic pain experience it the same way because of how we are so unique in everything that we do, how we see the world, all of our decision making. And so how I may feel or see the pain is very, very different than how you may be experiencing your pain. And I am here to assist you and what's good for you and how you will have the best outcomes for this. And so that's what I do, because the first thing I always hear is, well, did you take this, or did you give that, or did the person before me get this medication, or are you sure that yoga is going to work, or things like that. And so by putting it back and individualizing it on the person pulls it away from you. And that's what I do in my practice. But remember, I can cut at certain levels because I don't have that intimacy on a weekly basis that you have with your clients. Okay. So.
Well, I do very similar to you. Like, I make it individualized. And I was always, when I was trained that you don't self-disclose. And I know that's a preference of an individual with self-disclosure. So I do not self-disclose with my clients. So I make it, very individualized with them. If they ask me, well, have you ever experienced this? Very similar. I said, everyone's experience is different. And, we're dealing with your experience, your individualization, and I have them expand more on what they're feeling. And I know, Dr. Crowley, you asked about how it can be mentally draining on, us as practitioners, because if you are experiencing chronic illness or any, different situations that might hit close to home, it is draining on us. And so it's more, you're learning to take the step back, and it goes back to learning about self-care. How do we manage our own self-care? Because we do get a lot of information if you see private clients, on a constant basis, especially if it's a full day of clients and you're 8 hours, you have accumulated a lot of different issues at one time that you take on. And it's learning those boundaries of how do you separate each client from yourself and each client from each other. They could come in with very similar situations, but it's not the same, and they're not going through the same thing, and they're not experiencing that. When I teach certain classes, I always say to the future counselors, I'm like, you have to look at it when you open that door, take the hat off that you had on before you open the door. So if it makes it, you want to make it more mentally for you sometimes. So you're not the role of the mother anymore. Once you walk into that office, you're the role of the therapist. And when you walk in at home, you walk in as the mother, not the therapist. And I think a lot of that changed with COVID, when we had to go on to online and your practices was at home. So there was no separation between home and work. So a lot of us took a lot on and needed to learn different boundaries and self-separation and self-care. And that's the one thing I always recommend for future counselors is the self-care, to try to remember what your clients are sharing isn't your experience, it's their experience, and help them understand that it's their experience and how, as counselors, we can help them through their experience. If that answers the question.
Dr. Amy said chat, or in the chat, she said thank you. Do we have any other questions for Dr. Weiss and Dr. Weiss? You're welcome to put them in the chat or turn your mic on and ask. In that case, do you guys want to wrap up with?
Yeah, that's fine. Thank you for coming. I hope it was helpful, or I hope you took any, had takeaways, and thank you again for allowing us to present.
Thank you very much. Really enjoy presenting, and I like doing the interdisciplinary and interprofessional presentations. I think that's something that in the future we need to do more of.
Well, thank you, Dr. Alyssa Weiss and Dr. Sally Weiss, for presenting for us today. Thank you all for joining us. We hope it was wonderful. If anyone wants to stick around and ask a question, we have a few more minutes. Otherwise, thank you guys.
You're welcome.
Thank you.
Thank you, everyone. Have a good day.
Bye-bye.